Efficacy and safety of cold versus hot snare polypectomy for small 5 to 9 millimeters colorectal polyps, a multicenter randomized controlled trial. Introduction. Colorectal cancer, CRC, is an important cause of morbidity and mortality worldwide. CRC screening programs reduce CRC incidence as the endoscopic removal of adenomas prevents their progression to CRC. Hot snare polypectomy, HSP, has been the standard of care for the resection of lesions over 5 millimeters. However, cold snare polypectomy, CSP, has recently grown in popularity as it presents a low risk of complications even in patients receiving anticoagulant therapy. Furthermore, CSP shortens the procedure time. Thus, the recent European Society of Gastrointestinal Endoscopy clinical guidelines recommend CSP for removal of polyps 5 millimeters or smaller and suggest CSP for flat or sessile lesions 6 to 9 millimeters. There is contradictory evidence on the risk of residual polyp, and therefore an optimal assessment of the resection margin is of paramount importance. A pilot study evaluating CSP resection of 6 to 9 millimeter polyps showed important rates of retrieval failure and inadequate histopathological evaluation of the horizontal margins. Similarly, a prospective observational study concluded that the lateral margins of 67.1% of polyps less than 10 millimeters resected by CSP were inadequate for assessment. Thus, evaluation of biopsies from the margins of the mucosal defect is the preferred method for determination of the complete resection rate of CSP. A recent multicenter clinical trial conducted in Japan, which employed biopsies from the mucosal defect margin to compare complete resection rates, demonstrated that CSP is not inferior to HSP, 98.2% versus 97.4%. This result is supported by previous studies of lower statistical power. Studies comparing the impact of CSP and HSP on post-colonoscopy symptoms are lacking, however. A single-center trial reported a higher proportion of overall abdominal symptoms in patients undergoing HSP, 20% versus 2.5%, but the abdominal pain assessment was dichotomous without any further information about its temporal evolution. Therefore, the author's aim was to compare HSP and CSP for small polyps in terms of complete resection and to assess the association between the polypectomy technique and adverse events, namely post-procedural abdominal pain and intraprocedural and delayed bleeding. Methods. This was a multicenter randomized trial conducted in 7 Spanish centers between February and November 2019. Patients who were found to have 1 or more polyps measuring 5 to 9 millimeters were enrolled. Enrolled patients were assigned in a 1-to-1 ratio to CSP or HSP, regardless of morphology or pit pattern. After polypectomy, 2 marginal biopsies were submitted to a pathologist who was blinded to polyp histology. Complete resection was defined as normal mucosa or burn artifacts in the biopsies. Abdominal pain was only assessed in patients without polyps smaller than 5 millimeters or larger than 9 millimeters. Results. 496 patients were randomized. 237 patients with a total of 394 polyps to CSP, and 259 patients with a total of 397 polyps to HSP. Complete polypectomy rates were 92.5% with CSP and 94.0% with HSP. Intraprocedural bleeding occurred during 3 CSPs, 0.8%, and 7 HSPs, 1.8%. 1 lesion per group, 0.4%, presented delayed hemorrhage. Post-colonoscopy abdominal pain presented similarly in both groups 1 hour after the procedure, CSP 18.8% versus HSP 18.4%, but was higher in the HSP group after 5 hours, 5.9% versus 16.5%. A higher proportion of patients were asymptomatic 24 hours after CSP than after HSP, 97% versus 86.4%. Conclusions. The authors observed no differences in complete resection and bleeding rates between CSP and HSP. CSP reduced the intensity and duration of post-colonoscopy abdominal pain.